do people really sell their eggs?
I remember the days when we didn't have egg banks yet. And when I was first starting out in my practice, you need eggs. We'll go to this egg donor agency. You'll choose somebody to go through an entire IVF cycle. You'll have all the eggs from that cycle. And that's sort of the process is the match. And usually it's an anonymous donor. Sometimes people have a directed donor they might know, like their sister or their friend. But what's more common is just like sperm banks have existed for almost 50 years, the egg people have caught on because our technologies of freezing and thawing eggs have gotten so much better.
Hi, this is the Care Room with Dr. Cindy. Welcome. It's a space that was created just for you. I'm your host, Dr. Cindy, and this is a chance to get up close and personal with me. We're going to talk about the things in medicine that matter to you. We'll talk about the questions you've been carrying. We're going to have some honest conversations. We're going to hold space for joy, struggles, and everything in between. It's care that goes beyond the exam room. Care you're going to take home with you, whether you're listening while you're driving or you're listening while you're exercising. I promise that it's going to be care that's rooted in truth and a deep commitment to walking with you every step of the way. I'm glad you're here. Well, hello, hello, hello. Hi, everyone. Welcome, welcome, welcome. Welcome to another episode of the Care Room with Dr. Cindy. As always, I have another I know I say this all the time, but she's extra special. But you're a reproductive OB-GYN. She focuses on fertility, and she has graciously decided to bless us with her presence today and share her knowledge. But before I kind of butcher everything and mess things up, I'm going to let her introduce herself.
Thanks, Dr. Cindy. It's so wonderful to be here. So I went straight through to medical school and residency. I did my OB-GYN residency in New York City, and then I did my reproductive endocrinology and infertility fellowship in Michigan. So, technically I'm double board certified in both
Yes.
OB-GYN and REI. And once I got into practice, I realized despite my best efforts, I wasn't providing the care that I knew my patients deserved. And around the same time, I was engaging in some coaching calls and groups for my own personal growth and development. And I started to connect the dots. I was like, well, these coaching tools, I think this is what my patients need to help them make those really tough decisions, as we see so much of the time in the fertility space. Like, you know, do I move on to more aggressive treatments? Do I think about, somebody else's eggs or sperm, or, all these different questions that people have that can be so hard to, decisions are so hard to make. I started to experiment in the clinic, and I was like, "Oh my goodness, this is it. This is the secret sauce. This is what's going to help my patients connect the dots." And so then I thought to myself, I can't do this in the context of regular medicine. Like, I'm sure, you have your own practice that you've designed the
Right.
way that you want it to be, because
Yes.
we know that, the traditional medical system has so many limitations. And so I decided to start my own fertility coaching practice for female professional, where I help them, when treatments aren't working, to cross the bridge to parenthood. And we do that through community, we do it through one-on-one coaching, we do it through content in terms of engaging with some of the harder questions. And so that coaching practice is totally separate from my academic appointment. It's called Love and Science, Thriving Through Infertility. I'm super proud of it. I'm very passionate about it. And I
Excellent.
love that it's why I get to have conversations like this to help
Yeah.
kind of push the edges of what we know in traditional medicine and what we're learning and what can start to help people.
Absolutely, Dr. Bode. Thank you for what you do. I can only imagine the return that you get, when you have, a successful pregnancy. Can you tell us more? Yeah.
I get chills. I mean, daily people send me pictures, videos. Even yesterday, I was on a call with my team for Love and Science, and this
Sure.
person who's so dear to me now, I've been working with her for almost a year. She
Okay.
sent me the heartbeat. I teary to think about it. She sent me, she's 20 years of infertility,
Yeah.
and, she's gone through so much. And it was a combination of figuring out what medical treatment she needed and getting her A team and starting a GLP and really working on mindset. And after 20 years, she now has a heartbeat. And we know that when there's a good heartbeat, people have an over 95% chance of success. And so that feeling is just because you're like, okay, the hard work is done. The hard work
Yeah.
of this fertility journey is done. Obviously, there's still the pregnancy and parenting and all of those things, but for so many people, the hardest part is this part.
Right.
And many people drop out because it's so hard. And so
Yeah.
to get messages like that, to have people reach out to me on Thanksgiving and say, I'm so grateful for what you do in our community, to be sent baby pictures routinely. This is my 3-year-old. Thank you for completing our family. I can't even talk about it without tearing up because it's so meaningful
Yeah.
to me.
I love it. I love
Yeah.
it. Oh my gosh, they send you messages on Thanksgiving. That's so sweet.
I mean, I get Christmas cards and I get invited to birthday parties
Parties.
and
Yeah.
and it's just I think that it's such
Yeah.
a special bond that you
It's
form
almost
with
like
your
you're part
patient.
of the family.
Yeah, and it's a very intense connection. There's lots of
Yeah.
data points and touch points and there's highs and lows and so I think it's a very emotional process and to have a guide throughout that process, that's what I consider myself as a coach, to have a guide who can really help people to the other side. You never forget. I never forget a single patient. I never forget a single story because they all hold such a special place in my heart. Yeah.
Thank you for what you do. It's so touching. So
Yeah, and
touching.
thank you for what you do, Dr. Cindy. I mean, it's like the people of Pennsylvania are so lucky to have you because we
We
need healthy populations. We need
do.
amazing primary care. We need people who see the whole person like you do. And so much of medicine is fragmented and you reintegrate and bring it together. And so I'm grateful for you. If I lived in your community, you know who I'd be seeing for my
Thank you, Dr. Erica.
yeah.
Thank you. I appreciate that. Can you so our audience is busy professionals, busy moms, exactly what you described. So can you tell us when should we be worried about infertility? Like can you define what you guys consider infertility?
Absolutely. So, for women under the age of 35, if you've been trying with a male partner for 12 months and things haven't connected, then that's defined as infertility under 35 years old. If you are
Okay.
35 or older and you've been trying for 6 months, that is defined as infertility. Now, if you are in a same sex relationship or have other circumstances, that in and of itself is considered a reason to see a fertility specialist. And, sometimes if infertility is 1 in 6 couples, somebody might come to the fertility clinic and think, oh, I just need donor sperm or something like that. But if treatments aren't working, then that counts too. And so there's this whole spectrum of sort of what infertility is. And I will also say, though, don't get too bogged down in those timelines because number one, if you're anxious, say you're like 32 and all you've ever wanted to do is be a mom and it's been 7 months and your mental health is starting to suffer, there's no rule that says you can't go see somebody to talk about it, right? So I just wanted to offer that. And I also wanted
Sure.
to offer, like, if you're somebody who maybe has very irregular periods, or maybe you have had multiple abdominal surgeries, or maybe pelvic infections, and you might have some concerns about the fallopian tube. Maybe your partner had testicular cancer. Like, there's all these little reasons why you wouldn't go, like, quote unquote, buy the book and wait that amount of time. So if you're anxious, if you have irregular cycles, if you have risk factors for fallopian tube disease, like lots of surgeries or pelvic infections, or say there's something in your partner's history as well, a consult is a consult. It's information gathering. And so I find that people see me way too, after too much time, right?
Right.
Oh, it's been 15 years and we kind of forgot about it. And I'm like, oh dear. But,
Yeah.
see somebody on the sooner side is the message.
Okay. And that was my next question to you. Like, when should someone see you? When should we, family doctors, refer to you? So, thank you
Yes.
for sharing that. So, what does it look like once someone, books an appointment with you?
Yeah, absolutely. So, if I'm wearing my clinical hat, I have sort of two different hats. So, if I'm in my clinical hat working at the university, what I would do is I get 45 minutes with a patient. And if
Right.
they have any prior lab results or treatment, I look those over and then really get a detailed history. I always start, maybe I'm a little unconventional, but I really want to understand the person in front of me. Like, who are you? What brings you joy? What have you tried? What are you worried about? How many kids do you want? I'll think about somebody very differently if they want, 1 or 2 children versus say 7 or 8 children. Everyone has a different goal, right?
Right.
So we kind of
Right.
got to keep the whole picture in mind. And then, get sort of getting into the medical history in terms of, say it's a heterosexual couple. So the female's, medical history, surgical history, just like we always do, right? The traditional meds, allergies, family
Sure.
history, social history. I find there's a lot in the social history that is relevant. At least where I practice, so many people smoke marijuana or their partners chew tobacco, and there's like all these lifestyle things. And so I like to really get into it to understand, how are you sleeping? What's your stress level like? All those things. And then also, if there's a male partner taking the history as well, similar questions, trying to understand maybe this is a second marriage for people and the wife has two children but the husband has no children, and maybe he tried with a previous partner for 5 years and nothing connected. And so really just trying to like, I'm listening for, red flags, if you will, to be like, okay, what might be part of this in the history? And then, after that, like kind of at the end of the appointment saying, okay, well, this is what I see. This is what might be going on based on what I'm hearing. And this is the evaluation that I'd like to get. And so most fertility consults will, end with a sort of recommended testing, usually blood work for the woman, looking at what we call egg reserve. So looking to see if there's an egg number that looks reasonable for a person's age and not, that like their ovaries aren't acting significantly older. Also, usually some imaging, either an ultrasound or an x ray test to look at the fallopian tubes in the uterus, usually a semen analysis, which is a pretty straightforward test. Thankfully, thanks due to COVID, most people can produce sperm at home as long as they live within an hour. So
Okay.
that's gotten a little more personal. The collection room still exists, but most of the men are grateful to hear that. And then also just preconception testing, like anybody would do at a regular OB-GYN, to make sure people's vaccinations are up to date and
Right.
making sure they're taking a prenatal vitamin and those sorts of things. And also, we're even doing a little bit of genetic screening. American College of OB-GYN does recommend genetic screening to look for carrier screening for a couple different conditions. And then some people are even opting for more of that. So that's kind of like the first appointment. And then the second appointment is actually really even more important because it's like, okay, now that we have this foundation, come back and see me in 4 to 6 weeks after this testing is done. And you might say, oh my goodness, that's so long. But for most women, if a menstrual cycle is roughly 28 days, you need to
Right.
be in a certain part of your cycle for some of this testing, the blood work usually the first week of the cycle, the imaging the second week of the cycle. And so it can take some time to get all the pieces together. I always say, come see me when your testing is complete. So we're not wondering if there's
Yeah.
any gaps. Infertility is usually little things that line up, not like one giant thing. And so if I have maybe like all the female evaluation, but not the sperm test, at least up to 40% of the time, we're going to miss part of the picture. So people see me, we talk about options, and then I say, okay, from these options, you could either keep trying on your own, that's always an option, right? Or you could decide to do these various treatments. And then we could kind of go through the success rates and the timelines and the process and all those things, insurance coverage, and then people make their choices from there. So that's the clinical. I'm happy to talk about the coaching as well, but from the clinical side, that's what people can expect.
Sure, sure. So you mentioned the different methods that you offer.
Yep.
So that's my next question. Do you do
Yeah.
like egg retrievals?
Oh
What
yeah.
are yeah, okay. What does that
We
look
do the
like?
full gamut. So
Okay.
I like to start with a diagnosis and then work my way from there. So first of all, if there's any lifestyle changes that can be optimized, I know this is in alignment with your practice. We always start there because if somebody has even secondhand smoke exposure or say their partner chews tobacco, even weight, I know weight is very controversial, but we know that
Yeah.
there's an ideal range where people have the best outcomes. And so trying to help people support them to
Right.
get back to the gym, build their muscle mass, sleep better. All those things are really important. Make sure with supplements, I think people can go crazy with supplements and spend so much money, but there are a few things that are evidence-based that I do recommend, like folic acid for sure. And also there's one called coenzyme Q10. I think it has been shown in multiple studies to help with egg energy. And so if people take that over the counter, that can be really useful as well. So that first step is like optimizing people's lives. And then the second step really is then saying, okay, well, where do things seem to be not connecting? And so if somebody has maybe 6 periods a year and they miss months, I'm like, okay, well, you're getting fewer chances to try than other people. And so, let's see if we can do something to try and get your cycles more regular, right? So we can do ovulation induction with a medication called letrozole. That's usually our go-to medication. People tolerate that very well, very few side effects, and it's actually successful about half the time. So if somebody's just not ovulating regularly, that's a pretty simple way to start. People can either do that with home monitoring, like those ovulation predictor kits that you can buy at the pharmacy, or there's
Okay.
some
So you
situation.
do
Yeah,
recommend those. So you don't use
yeah.
fancy stuff. It's
The
because
fancy stuff, oh my gosh, it's TMI. I say TMI, TMI, too much information. So if you do want to track your cycles, either before fertility treatments or during, the brand I recommend, and I have no connection, I get nothing from this other than I want people to have a good outcome. The Clear Blue Easy non-digital ones I think those are the most easy to read because there's an open circle or a smiley face the day before somebody
Okay.
ovulates. And so,
Yeah.
get together with your partner that day, maybe the next day, and see what happens. But that
Yes.
means that the luteinizing hormone is spiking, which means that ovulation is going to happen in 12 to 24 hours. And then once that egg is ovulated, it lasts for about 12 to 24 hours in the female, body. And so sperm lasts much longer. They last for anywhere between 2 and 5 days. And so I always think about like a traditional wedding where like the bride is waiting, or the groom, excuse me, is waiting at the foot of the aisle for the bride to walk down. Like we want the sperm waiting for the egg is kind of the point. Yeah.
Nice.
So that's
Nice.
that's ovulation induction. And then if the sperm are normal, I tell people to try at home because there's no difference in success rates from trying at home versus in an office. And I mean, my experience has been that people like to keep things the least clinical possible, right? This is like, you know, if you think about
Absolutely.
yeah, how do people want to have a baby? They don't want a doctor involved, right? Most of the time. So we try to leave us involved as minimally as possible. But sometimes if like the sperm are on the borderline, or say somebody even has like unexplained infertility or endometriosis, those are situations in which there are clinical benefits to taking a sperm sample, concentrating it, putting the sperm in a small catheter, and then getting it beyond the cervix, which is like a big filter, getting the sperm beyond the cervix into the uterus to give more sperm a chance at reaching a good egg.
Can I put one question? And it's probably like a busting one, or
Yeah.
can you really use a turkey baster?
No, no, no. No, I
Okay.
mean there are people who like try to do home inseminations. I'll just say that for various reasons. And they use like a diva cup, or they use these different devices. And, that might be okay if somebody doesn't want to, or like I actually had a heterosexual couple. This poor woman, she had terrible, terrible trauma history and really couldn't have sexual
Yeah.
intercourse. And so the way that she got pregnant after an unsuccessful IVF cycle was with a syringe, actually. They put a syringe kind of close to the cervix, and that's what worked for them. So there are different options, but if you have true infertility, a turkey baster, which just puts sperm in the vagina, right? That's not going to be any better. There's benefits of having this small skinny catheter threaded through the cervix into the uterus. Very, very different. Thank you for asking that. Yeah.
Yeah. Yeah. Sorry to interrupt, but you were
No,
telling us
no,
like
no, no. Yeah,
the
yeah. So
different
there's
methods.
ovulation induction. You can sort of up the ante a little bit from the pills to induce ovulation. You can actually give like injections, which are a little bit stronger. Got to be very
Okay.
careful with those because we're always trying to create one baby at a time. And we know that twins and triplets are
5 or
higher.
6.
Yeah, oh gosh. Yeah, I mean, it really, especially in young women, you can really get to higher multiples with these medications. So you got to be very careful. But that's kind of the treatments that are outside of in vitro fertilization, kind of where the conception happens. The conception event happens inside the woman's body, and those treatments can be very successful depending on a person's age and their diagnosis and their other fertility factors. And so that's usually where I start. But if
Okay.
somebody either has several unsuccessful cycles of that, or if off the bat they have like no or very few sperm or blocked fallopian tubes, then we say, okay, well, there is this technology called in vitro fertilization. It's been improving over the last 40 plus years. And that's where we take 2 weeks to actually grow eggs inside a woman's body, which is so interesting because, like, just for your listeners, eggs don't like to be in isolation. Eggs are social. They like to be surrounded by other eggs. And we go through groups of eggs every single month, not just one egg at a time. So you might think, oh, the egg that I ovulate, that egg is like in a pyramid scheme. It's at the top, but it has all of its supporting buddies kind of underneath it in the pyramid. So
Girlfriends.
yeah, right, girlfriends. Yeah, girlfriends, thank you. What IVF does is it actually takes all of those supporting eggs, those girlfriends, and it puts them into the co-dominant role. It's kind of like if women
Mm.
took over the world.
Yes, I
Yeah,
love it.
yeah.
Sorry,
And
guys.
so, yeah, sorry guys. We still want your sperm, but what it does is, yeah, right. So it's like there's almost like community of eggs. And so, a healthy number of eggs for many women can be like 10, 15, 20, even more at a time. And so instead of all those eggs just like being lost and going away, like they would have inside the body, except for that one dominant egg that's ovulated, we can actually capture a large part of the cohort. So like, it's not unusual to get 10, 15, 20 eggs during an egg retrieval cycle, and those are eggs that would have gone away anyway. We're just capturing them. So that's the whole theory behind IVF is we get the cohort of eggs. We take 2 weeks with injections, and people come in about every other day for ultrasounds, blood work. That culminates in an egg retrieval procedure, which is done under anesthesia. It's a transvaginal ultrasound with a needle guide attached. And we go in under ultrasound guidance. We retrieve all the eggs from both sides. Then the lab sorts through the fluid under a microscope and gets those eggs. Then later that day, there's a sperm sample, right? So partner sperm, donor sperm, whoever's sperm, those eggs are then fertilized in the lab. And the next day, our lab does a check to see how many of those eggs fertilized. It's really important to understand that we as humans are very inefficient. So not every egg is going to be mature, which means able to be fertilized by sperm. Not every mature egg will even fertilize. It's about 70%. Not every embryo will keep growing to the point where it can, make a viable baby. And so there is loss at every point, but yeah,
Right.
exactly. But the whole point is to get to at least one good embryo that's going to make a baby. You can look at success rates online. There's a SART calculator. And then a bonus is if you can have embryos in the freezer so that if, say, somebody does want 2 or 3 children, you wouldn't have to do another cycle. You could go back to that group and just thaw an embryo and put it inside. So the way that somebody gets pregnant from this process is you create the embryos in a laboratory setting, you grow the embryos out, you see what keeps growing. You either transfer or freeze an embryo. Any embryo that's not transferred is going to be frozen if it meets a certain quality. If that person is pregnant that month, fantastic. If they're not pregnant, then we meet again and we see what we could do differently. If there's embryos in the freezer, we will often go to those. It's a much simpler process. Or sometimes we gear up and we do another IVF cycle. But you can see there's a lot more monitoring. There's a lot more cost. There's a lot more, there's anesthesia. There's a lot more to go through. But for many people, that is how they build their families. And I'm just so grateful to live in a time when this technology is available for people. And it keeps improving, which is the wonderful
Yes.
thing.
Yes. That's
Yeah.
the beauty of medicine. I love it.
Yeah. Yeah.
So, just some common questions that, the listeners will have. Is it painful at any time during the process? Any process trying to
That's a
get
great
pregnant?
question. Well, I just want to say that going to a doctor's office for reproduction, that's like emotionally uncomfortable. Like I've never met
Yeah.
anybody who is like, I just can't wait to go to the fertility clinic. There's something
Yeah.
people just don't want to have to be there. And I think that we have to call that out up front because the more we can normalize that discomfort and look for strategies to come together and say, like, how can we work through that? I think that's really, really important. There's all these feelings that come up. There can be guilt, regret, shame, partner disagreements, all those things. And so, we can't really do anything unless we understand the emotional context. Not everybody, everybody experiences these things differently. And some people do have very strong relationships that get stronger through the process. But I think we have to say, okay, there is this part that is maybe the hardest part, which is the emotional component. And then we can talk about the physical symptoms.
Yeah.
So that having been said, I will say ovulation induction. I mean, if somebody is not used to ovulating and they ovulate for like the first time, whoa, is that an event? They're like, what just happened in my body? Like, boom. I mean, you can look at actually like electron micrographs and see like
Yeah.
it's like this explosion that happens on the surface of the ovary. It's so fascinating the way that it happens this way. So anyway, so like if somebody's used to ovulating, okay, fine. But if somebody's not, they're like, oh my goodness, what just happened? Right. So I just want to say that the procedure itself for the insemination is generally not uncomfortable. That can, cause some cramping for sure, but nothing unusual. Backing up a step, like the evaluation itself, like, getting your blood drawn is not comfortable. Especially most of these people are like young, healthy women. And so like they might not have ever had their blood drawn, right? This might be like
Right.
the first time. And
Right.
then the uterine cavity test, the fallopian tube test, those can have some discomfort associated with them. So I always, if it's not contraindicated, I recommend that people take ibuprofen ahead of time. They kind of don't just rush to their next thing because I think oftentimes people are surprised at how uncomfortable those diagnostic procedures can be. If we're talking about, sort of more involved stimulations or in vitro fertilization, the complaint that I hear the most, and actually I have gone through this myself, so I can speak to my own experience as well, is just this bloating sensation. And so the ovaries are about the size of like clementines, to put them in relative terms. And with a good IVF stimulation, they can grow to be the sizes of like oranges or even grapefruits. So that's a big change, right? That happens over about 10 to 12 days. It's pretty quick. And so if you imagine like the capsule of the ovary is stretching and those ovaries are taking up space inside the abdominal cavity. And so sometimes they can press on the bladder or the bowels. Constipation is a very common complaint. And people just feel kind of bloated. And they're like, I feel like I look pregnant, even though I'm not yet pregnant. Like, what is going on? So just, acknowledging the bloating. Once we do the egg retrieval, people often feel like kind of a little bit relieved because they're decompressed, right? All those like quote unquote water balloons that are the follicles inside the ovaries, like they get drained. And so that's its own sort of relief. But sometimes there can be some discomfort after the procedure because a needle has gone in and retrieved those eggs. And so
Got
ibuprofen is usually sufficient for most people. I recommend
Okay.
you. I mean, you can't work the day of your egg retrieval, but not rushing back the next day is sometimes
Right.
advisable because you don't quite know how much you're going to feel, and it is just nice, to give ourselves that grace of like everyone's a patient at some point. I'm going to let myself heal and recover, and then I'll go back when the time is right. Yeah.
Absolutely. Thank you for that. And then for the mom or the lady out there
Yes.
who, they've been trying either to have another baby or it's their first, and they're concerned about cost. Like, how feasible is it to go through a process like this?
Oh, such a great question. It really is all over the map in terms of whether insurances will cover. It really does depend on a person's insurance carrier. Some people offer this, some plans offer this, and some don't. So I always say open enrollment is a really critical time because if
Okay.
you can get on your partner's insurance, if you're not currently, or maybe you have a different plan, maybe like a slightly more expensive plan that you haven't signed up for, but like if it saves you like 40, $60,000, right? Like it's going to be well worth a few extra $1,000 a year in the premiums. And so really getting educated about what insurance options are available to you, I think is really important because it can be all over the map. Most fertility offices do have a financial person who can help to sort out these things, but it's always useful to call your own insurance and see. I mean, I will say, relatively speaking, the less involved treatments we talked about, like, letrozole for ovulation induction, and, inseminations, if usually a few $100s, like those things are still very expensive, but not like, not the thousands and thousands of dollars of IVF. Most IVF cycles are going to run anywhere between dollars and up, sometimes 20, even in like California, it can be $30,000, New York City. So, or even more expensive. And so I really think that, the hardest part is that many people need more than one cycle too. And so how can you plan for this? People ask about grants. There are some grants. We recently had a patient who got a grant for $5,000 through an organization. So you can look online for those. But also just like being very savvy in terms of understanding your insurance, what insurance options are open to you. I've even had people change jobs based on a better insurance. There's some companies that boast really good fertility benefits, and so looking into those as well. But unfortunately, Pennsylvania is not a mandated state, and that means that there are states like New York is one of them where insurance has to cover IVF, full fertility treatments for their employees. But I will say, Dr. There are so many loopholes. So
I'm
just say
sure.
you're listening to this and that you're in a different state, like, like New York, like if your employer is self-insured or if there's, a small company under 100 people, like there are all these different things written into law that, unfortunately, like for us, when I was practicing in New York State, like all the hospital employees were excluded from coverage because their hospitals were self-insured. And it was like all the nurses and doctors who were providing the care to other people who couldn't get their own care covered, which
No.
is like there's, we could go on and on about that, but
Yeah.
I think, being very financially minded, I think is helpful because we can't ignore the finances of this process. And sometimes it can be very expensive, especially if insurance doesn't pay for anything.
Sure, sure. Thank you. Thank you for
Yeah.
sharing that. And then it's gonna probably be my last question to you because we're so we're so conscious of your time here.
Thank you.
I in myth busting again, and I guess this would be the flip side to what we just talked about. But do people really sell their eggs? And I, as a
Yeah.
doctor,
Yeah. Yeah.
I am familiar with that because I know we have egg banks, and those are so valuable and such a great resource for so many families. But if you can
Yeah.
touch on
Sure. So I'm old enough that I remember the days when we didn't have egg banks yet. And when I was first starting out in my practice, we would say, okay, you need eggs, we'll go to this egg donor agency. You'll choose somebody to go through an entire IVF cycle, you'll have all the eggs from that cycle. And, that's sort of the process is the match. And usually it's an anonymous donor. Sometimes people have a directed donor. They might know like their sister or their friend, but usually these things are like, an anonymous person says, I want to donate my eggs. And then somebody would say, okay, fine. Now, actually, what happens is what's more common, we can still do it the first way, but what's more common is just like sperm banks have existed for, almost 50 years, the egg people have caught on because our technologies of freezing and thawing eggs have gotten so much better for the
Right.
last like 10 plus years. We've actually, ASRM, our governing body, American Society of Reproductive Medicine, has said that egg freezing is no longer experimental. So the nice thing is that because these technologies have improved, that say somebody produces like 24 eggs in an IVF cycle, right, an egg donor, that those eggs can be divided into groups of 6 eggs. And so
Mm,
for a flat fee, people can say, okay, I'm going to purchase 6 eggs from this donor for this much money. And then maybe family B is like, okay, I like that donor too. And obviously there's monitoring to make sure there aren't too many genetically related siblings in the same geographical area. But it's streamlined the process because the eggs are already ready to go. You don't have to like wait for somebody to go through a whole cycle and be like, oh shoot, I have a wedding, I can't do it that month, all those different things. But I will say, people should know that the egg donors are screened so rigorously. There was a study that showed that only 8% of people who applied to be an egg donor actually got to be an egg donor. And in some agencies, it's like even lower than that because they screen out for like genetics reasons or mental health reasons or other reasons. And so the egg donors are very carefully screened. I will also say many of the egg donor agencies, it's really hard to get a diverse pool of egg donors. And so, so many
mhm.
people want somebody, who's going
That's
to,
right.
right? They want somebody who looks like them. And I think that we're finally starting to see more and more diverse egg banks because
Okay.
we need that.
Yeah.
And I'm so grateful that now I've seen this in my career, which is, 20 years later, I've started to see that people are doing this and that many women can find an egg donor who looks like them as they should or has a certain cultural background that resonates with what they want for their offspring.
Yeah. Yeah.
So yes, people can do this. There are many reputable companies. Any fertility specialist who you know and trust is going to steer you in the right direction in this regard.
Yeah. Thank you, Dr. Erica. We are so grateful for your info, for your time. Guys, this is Dr. Erica Bove. She's in Albany, New York. Can you share with us if someone who has been listening, they loved what they heard, how can they find you?
Absolutely. No, I think we didn't touch on too much. We started with the emotional component, but the fertility journey is so very isolating. And so my true passion is to help women
Sure.
navigate this process in a way where they can thrive and where it doesn't take everything from them. So many people come to see me and they're like, it's all I can think about. I'm not sleeping. Like my husband and I are like on the road to divorce. And it's like this
Yeah.
process ruins lives. It ruins relationships. It's terrible. And it doesn't have to be that way. And so my coaching is what obviously I love the medical part, but the coaching, I'm passionate about giving people the resources that they need to navigate this. So I have a podcast. It's called Love and Science Fertility. Everything I do has the same name. So my Instagram, follow me on Instagram, Love and Science Fertility, Facebook, LinkedIn, whatever, wherever you get your information. But start listening. If you heard something where you're like, you know what, like I'm really struggling, this is affecting my marriage, any of those things, there are resources for emotional support, and I'm passionate about helping connect people to those resources. So loveandsciencefertility.com is my website. Like I said, all the other places, but know that you're not alone, know that resources exist, and we have figured out a way to help people through this process. It's just not people just don't know about it yet. So go check out the resources, and I'm always rooting for you. Always, always.
Thank you, Dr. Erica. Thank you for the gift that you are to the families who need you.
Thank you, Dr. Cindy.
Thank you on their behalf.
Of course. Of
All
course.
right, guys. So this has been another great episode of the Care Room. As always, next week we'll have another awesome doc with us. But until then, take care.
Thank you. Bye.
Thanks for spending time in the care room today with Dr. Cindy. If you liked what you heard, please subscribe, share this podcast. I'm also on Facebook and Instagram. You can follow me there. Remember, you're not alone in this. There are doctors who do care. The information in this podcast is for educational and informational purposes only. It is not a substitute for professional medical advice, treatment, or diagnosis. Always, always consult your personalized healthcare provider for medical guidance.